Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 44 of the OBGYN podcast. This is the Journal Club for October 2018, but before we get there, I want to take a minute and talk about something that maybe is a little uncomfortable for me, and that's money. And I've been working at this hobby of mine for the last 2 years and have been privileged to get to recruit some great people to help bring in some different perspectives, and you'll hear a couple of those people tonight. That being said, it takes a lot of time for me and my guests, as well as the cost of hosting the files and the website. Therefore, I'm starting to look at different ways to bring in just a small amount of money to cover the cost of hosting as well as compensate my guests for their time and energy. So I spent a lot of time thinking about this, and for now what I've done is I've set up a Patreon account so that listeners can support the show if they so desire. Patreon is a service that allows an audience to donate a small amount of money on a monthly basis. It's been around for a number of years, and it's easy to use and secure. Now, I do not plan on locking any content behind a paywall, so whether you donate or not, you'll have access to everything that we create here at the podcast. But if you do feel that you value this content enough to contribute, then please click on the link in the show notes or head over to the website, obgyn.fm, and click on the support page to get there. You can give $1, $5, $10, $25 a month, whatever you think it's worth it and that you can contribute. And anything that you do give is appreciated. And even if you don't give anything, just listening is appreciated. All right, well, with that awkwardness out of the way, let's get into today's show. We're going to be talking about the paper in this month's JAMA titled Effect of Immediate versus Delayed Pushing on Rates of Spontaneous Vaginal Delivery Among Nulliparous Women Receiving Neuraxial Analgesia, a randomized clinical trial. Whew. And to do that, I have two wonderful guests. Dr. Jerry Ballas is back with us again, and Dr. Jen Blaber as well. Thank you both for being here.
Glad to be here.
Happy to be here again.
So let's get into it. The debate over laboring down has been raging for at least a decade now, probably longer. Proponents will say that allowing passive descent allows women to push for a shorter period of time, avoids unnecessary stress on the pelvic floor, and decreases the section rate. Opponents point to data that show that there is absolutely no change in those outcomes, and that laboring down just takes longer. And I want to stop here for a second and say that all these papers ignore, actually not all of them, because this one doesn't, one important aspect, and that is patient experience. And we're going to get into that later, because this paper actually does talk about it. We in medicine tend to focus on objective outcomes like time to delivery, time spent pushing, section rate, maternal and neonatal outcomes. There's a whole lot more here than just that. A lot of it is also about what a woman wants and how she perceives her labor. And so I am actually glad that they included that here. It's harder to quantify, but at least in some cases, equally important. So before we get into this actual study, I want to ask you both what your experiences with laboring down and kind of where you're starting this. Maybe you have a bias. I don't know. Jen, let's start with you. What do you think?
I think that in my personal experience, I'm not a fan of laboring down. However, I think that in my practice, my initial practice was not to labor down. And then I think I became more comfortable with the idea of, maybe this will give patients a better outcome and letting them labor down as per the more recent guidelines. And then with this paper, I guess it reaffirms where I was in the beginning of my practice. Laboring down isn't going to help anybody. In my own delivery, I did not labor down either time and had a very short second stage.
Fair enough. Jerry, what do you think?
So my experience now, I'm definitely in a practice with a very active midwife group on the laboring floor. We actually have 2 rooms set aside for birth center type experience. So I've seen a lot more of birth plan type interactions coming into a labor. And I feel like expectations are much wider in terms of how labor is kind of explained to patients, especially nulliparous patients coming into the labor floor. So I think laboring down is actually, I've seen it become kind of part of the interaction between the provider and the patient when it comes time. I've seen more conversations about laboring down initiated by patients than I ever had before. So it's definitely something that's gone beyond our literature and is now out there, like you said, in the last decade for women to include as part of their expectations and journey through labor. And so I've actually kind of gone both ways in this paper. The one way to look at it is that when we're jumping the gun, there's no difference if a woman immediately starts pushing, but you can also say, well, then there's also no difference in letting them labor down, except we'll get into the nitty gritty of some specific differences between the two groups. So I don't think this paper did anything to really hugely dissuade the folks that want to, feel more urge to push. But I also don't think it's suddenly going to become a requirement that once we hit that magic 10, a bell rings and everyone runs in there and starts pushing.
Right. I think at Stony Brook, at least, what I have seen is it has been kind of caught up in this demedicalization of labor.
Correct.
Right.
Yep.
Where doctors are no longer forcing women to start pushing right away. We let them listen to their bodies and start pushing when they feel like they need to or they want to. And I'm not saying that in a negative way necessarily, except to say that any kind of decision to try to change that back to active pushing, at least at Stony Brook, is going to run against a wall of not just the patients and the midwives, but also the nurses now. The nurses feel like in some ways they're protecting the patients from the doctors. And they're going to push back on us if we want them to start pushing right away. And so I don't know how easy it is going to be to change that culture back, not because of evidence, but because of culture.
The other part of this to remember, though, is all these women had epidurals.
Correct.
Right? So that's the one big step we have to remember with this paper, is that these are all women that have opted for an epidural during labor. So that actually, at least in my experience, typically removes a certain percentage of women that are very aware of medicalization, do not want intervention, and probably would not be part of this group because they're going to feel everything and their body truly is going to dictate, when they're going to start pushing, whether they want to or not. So that's one way to kind of frame this paper, is that, if you're going to talk quote unquote natural or so forth, this isn't that paper.
Agreed.
You've medicalized your labor. You put an epidural in. So don't suddenly bring into me this notion of delivering in the woods with harps in the background. We've put in an epidural. So, we've kind of left the overall natural birth at this point.
I actually may push back a little on that one.
That's fine.
I think you're right. I think what you're describing, there's a certain class of patients who really embody that kind of stereotypical natural childbirth. But I think there's a large middle ground where
absolutely.
They want the bare minimum done. They don't want to be in pain, but they also don't want to Pitocin. They don't want they don't want all these things necessarily, interventions. But so I think there's a middle ground here that this paper could apply to.
Mm-hmm.
So we'll stop into the paper, I guess. What they say, the authors say that the reason they did this trial is that there is some data out there, some randomized controlled trials, which they didn't think were very well done or could have been done better. There was some meta-analysis, one that didn't include these suspect trials, and they found there was no difference. And then the one that did include all the trials found a difference. And so they really set out to say, we want to answer this question once and for all. And we design the best study that we can. And this is one of those impressively designed studies, and the amount of work that goes into it. I look at this study and I say, how did they do this? I mean, it is so much organization amongst so many places. It's really, truly impressive. And it takes a group of people who are very dedicated to get something like this done.
Based on the way patients were randomized at all, think of the number of people involved in this process at each of the institutions. It's amazing. I mean, having done small randomized trials at Stony Brook, this is huge. So what they did is this is important. They included Nulliparous, singleton, term, cephalic
pregnancies with an epidural and a reassuring tracing. Now, they did not characterize that by category. They just said reassuring, which I'm sure was done on purpose because not everyone was there looking at every tracing to say at any given time it was category 1, 2, or 3. But we can assume at least they weren't category 3 tracings. Right? None of these people had worrisome tracings. They had 6 centers, and that's impressive. So they had WashU, they had Missouri, UPenn, Penn Hospital, University of Alabama, and the Oregon Health and Science Center Hospital. And at least 4 of those hospitals are gigantic places. The 2 I don't know, and maybe Jerry, you know more about them, is the Missouri Baptist Medical Center. I'm not familiar with that one. And the Pennsylvania Hospital. I don't know how big those are, if they're academic centers.
I think with Baptist, it's a very active community hospital that does a large volume and is very, if quasi-academic, we'll say. A lot of the faculty, I think, are known to have either been through the WashU system, associated with, and so forth. And then Pennsylvania Hospital, I do not know much specifics about. But my guess is, with the powerhouses you named, all of which either are current or have been members of the MFM units network, in terms of infrastructure, in terms of study coordinators, and having people to randomize and collect data and so forth, they would not work with hospitals that don't have similar abilities and infrastructure.
Fair enough. I mean, now that you say that, the relationship between Penn Hospital and UPenn is probably similar to that between WashU and Missouri Baptist. That makes sense.
Correct.
Okay. Interestingly, the rate of immediate pushing across the centers was about 50% before the trial was initiated, which I thought was interesting. I would say it's much lower than that here at Stony Brook. I don't know what it is where you are, Jerry.
I'd say about 50%. I think it usually falls along, kind of like I was talking about, the practitioners that are involved in the labor course.
Fair enough. So they enrolled women who were, well, I should say they enrolled women. They don't really say, but I'm assuming they enrolled women at time of admission for delivery. They were randomized when they became fully dilated. I doubt that they actually consented them at fully dilated, but they don't say.
I would hope not.
I would hope not. You'd have to wonder, even with epidurals, you still have to wonder about, can you really make an informed decision to join a study after you've been in labor for 12 hours or something? But anyway, so they were randomized to either immediate pushing or to wait for 1 hour. And again, I'll say that, at least in my experience at Stony Brook, women often wait much longer than 1 hour to start pushing.
Right.
So that I thought was kind of not an odd choice, because again, I don't practice where they do. Maybe that's the normal where they are. But it's certainly different than what I see in my own practice, and so I have to keep that in mind when I'm interpreting the results.
No, I agree. When I think laboring down, my actual automatic in my head is 2 hours, right? I mean, that's almost, I remember some teaching, even at residency, like, don't call them fully dilated, call them anterior lip and give them 2 hours to labor down. My guess is that they toyed with the idea of 2 hours. But honestly, you would get women that would just have the urge to push before that 2 hour mark. And so you may end up kind of muddying the waters of your outcome, or crossing over a little bit more into what you call immediate versus delayed. So I think that's the compromise they made there.
Fair enough. And we do see, even with their 1 hour, we do see a pretty wide range when people started pushing, most likely because of their pressure or other symptoms. Once they started pushing, the maternal position and technique, duration, frequency, all that stuff was at discretion of the patient, her nurse, and her clinician, which makes sense. That'd be hard to dictate by protocol. So let's get into their endpoints. So their primary outcome, interestingly to me, was spontaneous vaginal delivery. There are some other primary outcomes or other alternative primary outcomes that they could have gone with, and they use them as secondaries, but duration of second stage, duration of pushing, I guess operative delivery and cesarean delivery kind of go with the spontaneous vaginal delivery. But I think the duration of second stage and duration of pushing, either one of those could have been their primary outcome as well. So I don't know, why spontaneous vaginal delivery? Is that, you think, from previous literature, or was there some other reason you think they chose that as opposed to one of the other ones?
I think they chose it because the other one's common sense is going to say that somebody's duration of second stage was longer.
Fair.
Right? So I think they really kind of went for the beat of the issue, which a lot of people right off the bat are going to want to know is, am I going to end up with a worse C-section waiting for a woman to try to push, or do I need to get them to start pushing now to avoid having to do a morbid arrested descent, 3 hours worth of pushing C-section? So that's my guess is where they kind of went with the outcome, the bigger, more translatable outcome. Because otherwise people are like, yeah, she's going to be there for an extra hour at least. So we're going to add time to that. And in terms of duration of pushing, I think previous data shows you're not going to have some sort of dramatic, 1 to 2 hour actual pushing time difference. I think they want to know whether I'm going to be delivering this person vaginally or not.
I think that makes sense. Jen, any thoughts on that?
No, I think that makes a lot of sense.
Yeah. And then there's other secondary outcomes were postpartum hemorrhage, chorioamnionitis, lacerations, the dreaded neonatal composite outcome. And if I have one problem with this study, it's going to come down to that. We'll get to that a little bit later. Levator ani injury, which I thought was very, very interesting. And we could talk about that a little bit. Incontinence, pelvic organ prolapse, and a quality of life survey. They also use this other survey for satisfaction with their labor course, which is interesting, and we'll touch on that in a little bit. So then sample size, and we were chatting before we turned on our recording here, and Dr. Ballas pointed out, because he knows some of these people in the study, at least by reputation, this study is very solid, and so their sample size is also very solid. If you're looking for a way to write your sample size or your methods in general, you can't go wrong with just copying the way the paper does it, because it's fantastic. So they calculated 72% vaginal delivery rate for delayed pushing group. That comes from literature. And in order to detect a 5% difference between the groups, they calculated a need for 1,592 in each group. The data was analyzed for safety at 50% and 75% enrollment, which is going to come into play here. And they decided that the trial will be stopped if any significant difference noted in the primary outcome with a p-value of less than 0.001, which is very significant. And actually, interestingly, the trial was not actually stopped for the primary outcome. It was actually stopped for a secondary outcome, which is interesting. And it was stopped at the 75% mark, which they're going to talk about in their limitations, because it does decrease their power somewhat. So they actually ended up enrolling 2,414, 1,204 in the immediate group, 1,210 in the delayed, 10 withdrew from the studies. They did a very nice randomization because they had absolutely no differences in their baseline characteristics. They have one of the longest tables for baseline characteristics I've seen, and there's no significance there. So time to start pushing. Here's the first thing I found interesting. So the time to start pushing after fully dilated in the immediate pushing group was 18.9 minutes with a standard deviation of 15. Which, again, working at Stony Brook, and Jerry, you've worked at other places too, but to get anybody to start pushing within like 20 minutes of being fully dilated, you got some good nursing staff there. Because I don't see that at Stony Brook, at least not that often.
Right.
And then for the delayed, their average or mean was 59.8, which is right along with their 60, but they did have a standard deviation of 21.8. And I think that probably goes into what we were talking about earlier. Some women just have the urge to push sooner, and so they're going to push sooner. But still, it's a pretty wide variation there. Let's see. Before I get into the actual outcomes, stopping there with their the methods done and the results, do you guys have anything that kind of stood out to you in their methods or in their immediate who got enrolled and who got X-rolled and that kind of stuff?
What stood out to me was in their figure 1 where they talk about the 10 patients that they lost in each group. I was confused that some of them never became fully dilated. because this is after randomization. Do you see that?
Well, that is a good point.
It caught me up because at randomization, the patient was fully dilated. And yet 4 patients, 3 on one arm and 1 on the other, were not completely dilated after randomization.
Do you think that was maybe someone called them fully dilated and they actually weren't when the next person went to examine them?
The dreaded backwards exam.
Yeah. Maybe.
I mean, we all know that happens. We see that.
Right.
Yeah.
Patients love that.
These were all done in July, all 4 patients.
It's just something that caught my eye when I was looking at the table because that was after the randomization step.
Yeah. I actually was interested, and I think they go into this in the supplemental data, but 1,204 were randomized to the immediate pushing group, 11111 received intervention at randomization as randomized, and 93 did not. And then when they actually do their data, though, they keep it at 1204 and 1210, and they do talk later about intention to treat versus not, and they found that there was no difference. But it's kind of buried later in the paper.
Right.
And I think it would have been nicer if they had brought that up in the beginning of the results, but that's just a nitpick.
Just as a funny aside, I would have loved to have seen a loss to follow-up. Just curious what would have happened there. Look at them. They have to put in their 0 loss to follow-up. Yeah. Where are these epiduralized women going to go? Just curious. Sorry.
Yeah, they eloped. They delivered in the bathroom. Who knows? All right, so primary outcome, as we kind of alluded to earlier, 85.9% versus 86.5% spontaneous vaginal delivery. That was 0.67 p-value, so it's not significant. Actually, another nitpick. I was always taught when doing your numbers that if you had a point, you should always have a 0 in the front of it, so 0.67.
Correct.
And they do not do this at all in this paper. And maybe it's a New England Journal format thing.
You mean in the p-value side?
Yeah. They're all just 0.67 or point something. There's no zeros, which I guess we're not prescribing medications, and maybe that's where I picked that up from. But anyway, I noticed it today. Nitpicks. As far as secondary outcomes, there's second stage duration 102 minutes versus 134 minutes. So even with the delayed, it was only a 34-minute increase in their second stage, despite waiting an hour, right? Actually, I guess there ended up being like 19 minutes versus 60 minutes. So it's actually 40 minutes there. It actually almost makes up completely, I guess, there. You're losing that 30 minutes as far as waiting to push. So it didn't delay things too much longer. Active pushing.
Says the man that's never pushed the baby out. Just saying.
Fair. I'm willing to take that. Active pushing was 83.7 versus 74.5, and that was significant. So that's a 10-minute difference, which is not a huge difference. And all these numbers, by the way, they seem pretty reasonable. Like basically an hour and a half for pushing in a nulliparous woman is about right? So I was not too surprised by that. Their operative delivery rate was 6.3 and 5.9%. And that was not significant. Cesarean delivery was 7.8 and 7.6, which is also not significant. Now, I'm impressed by that cesarean delivery rate. I'm not going to lie.
Well, this is cesarean delivery rate at time of pushing. This is arrested descent C-section
that's
rate.
True. You're not including the
one thing I'm curious about, which I don't think they state unless I missed it, what is the overall laboring cesarean delivery rate at each of these locations?
Well, they don't say.
They do not remark about that.
I don't know how I was trying to think in my head how that could potentially play into this in terms of the whole like screening out at each place different labor abnormalities or labor dystocias or tracing issues, etc. But yeah, I don't see what the background C-section rate at these places are.
Yeah, it probably wouldn't have made a difference. Especially, I mean, if there were actually a difference in these two, I'd be a little more concerned. But the fact that they're the same makes me a little less concerned about that kind of, I don't know if bias is confounder, I guess is probably the better word. But you're absolutely right. The rate's probably that low because they're taking out all of the non-reassuring, all that kind of stuff. That makes sense. Okay. Postpartum hemorrhage, 2.3% versus 4%. That was significant. It's statistically significant, clinically significant. I mean, it is there. It's an extra percent and a half. So it's not nothing. But I don't know.
But this is why it was stopped.
Correct.
Enrollment was stopped. And my guess is because of the outsized attention postpartum hemorrhage gets in hospital quality measures. So remember, like, a incidence of postpartum hemorrhage gets a full, check +1 when doing your quality measures. And that right there is going to get the attention of all of your QI people, your administrators, and so forth. So my guess is they were very, very acutely aware of their hemorrhage rates, because most hospitals aren't going to tolerate increased hemorrhage rates for the good of science.
Yeah, I mean, especially Jen and I are aware of this. The Safe Motherhood Initiative has certainly made a big push, at least into our hospital, and hemorrhage is one of their trifecta that they're working on. So we see it. And as you mentioned, it was the reason at the 75% enrollment that they decided to stop the study. One, because they did have that increased postpartum hemorrhage, but also because they found that there was no difference in their primary outcome.
Right.
And we'll get into what they calculate on the power on that later. But they were happy enough with that. Actually, I kind of got the feeling a little bit that they didn't want to stop, but that they were forced to stop. That's reading between the lines. That's kind of
the way they wrote their limitations. I do not think they were happy to stop.
Yeah.
But,
they sold it as well as they could. Chorioamnionitis, 6.7% versus 9.1%. And I'm interested in what you guys think about this, because they really chalked that up to this extra time. But
when was it diagnosed?
Well, so good question. But it was only 30 minutes. Like, if it was like 3 hours or 4 hours, I might say, okay, well, 3%. That's a big difference, 3%. That's not nothing.
Right.
So I don't know. I mean, besides when was it diagnosed, what do you take away from that, Jen? What do you think?
I think we need more information. I don't think we have enough information to say where they're getting that 3% from. And I didn't open all the supplemental information. I went through some of it, but I don't think we have that in there.
Yeah, I mean, one of the things, I'm trying to think if I saw it, was time of rupture, which I don't think they included.
I don't think so.
And so I don't know that was necessarily the same between the two groups, and maybe that explains it. But I can't believe that 30 minutes equals 3%.
And what's their diagnostic criteria is the other thing I want to know. And remember, we have 6 different hospital systems here, and as far as I know, there is no universal diagnostic criteria. So where did all of these diagnoses come from? Is there a breakdown in the supplemental that shows which sites had the chorioamnionitis? Could there be a diagnostic criteria that's affecting things as well? I'm not sure. Because like you said, it doesn't seem, right off the bat, you could say, well, of course, a woman's pregnant longer, more chance of chorioamnionitis, but that just seems like such a small amount of time that I wouldn't imagine would represent that much of an increase. It is interesting.
Jen, you're shaking your head there.
Because I'm looking at their table too, and they footnote some of their terms so that they can give you definitions, and they did not footnote chorioamnionitis to any criteria.
Right. So that may be a hint that, like Jerry said, it wasn't standardized across the 6 places. Now, that could be, having done studies not as complicated as this, there are certain times where you go back and you say, oh man, like, we didn't standardize that. Like, and then you're like, should I include it? Should I not include it? But then it's one of the only things that you have is significant. And so you're like, I guess I'll include it. And then, I'm not saying that's what happened here, but that does happen sometimes where you go back at the end of your study and realize that something that you may want to standardize, you didn't do it. So that could be it.
Yeah. And I remember, Choreo came up, just as an aside, with the papers that were promoting early rupture, early amniotomy, early management, active management of labor. And when they went through, they specifically said at the end of that paper that we couldn't assess chorioamnionitis because we weren't powered for that. And so it's interesting that I think more people would be very interested to see chorioamnionitis in terms of early amniotomy, active, Dwight Rouse method of managing early labor versus whether choreo from waiting an extra hour and pushing 30 minutes. I don't know. It is interesting. I may actually kind of sidebar who I can at SMFM this year and find out more about this.
All right. Well, if you find something out, you can bring it back.
I'll let you know.
So next they had this neonatal composite score. Anyone who listens to this podcast knows that I hate them. We actually
let's not go down that path.
We actually had this debate at our own journal club at Stony Brook last week, and I expressed my disdain for neonatal composite outcome, and one of the MFMs, who will remain nameless, essentially said, yeah, Joe, but then we wouldn't be able to do any OB research.
Correct. In this country.
Yeah. Right.
Asterisk.
Right.
Right.
And that kind of was my point, but that's okay. And the reason I have an issue in this, okay, first of all, it was no difference, but one of the issues I have in this particular study is that they actually do break out all the outcomes by themselves. So if they were going to do that, then why have a neonatal composite score? That's what I don't get.
Transparency,
I suppose.
To tell you the truth, I really think it is. I think it's... And they also had the numbers to do it. So, again, I think this is a way, again, of showing the vast number that typically you don't get with this kind of study. I mean, if you have a big enough number where you can give me, meconium aspiration, transient tachypnea, but still you had zero. Of all these patients, you still had zero in the immediate pushing of meconium aspiration and 2 in the delayed.
That's so rare.
Right. So I think that's probably why they broke it down too, is because they could.
Fair enough. I mean, the only thing they found was an increased risk of acidemia, defined as pH less than 7.1, which people listen to my antenatal screening podcast series will recognize as being meaningless, was higher in the delayed pushing versus immediate pushing. And again, as far as we know as a field, that's clinically, unless it's really, really low, like 6.8, it's useless. So I'm not sure how much that is important, but there that is. Perinatal,
and then suspected sepsis, but that's, I think, intertwined with your chorioamnionitis, depending on policy.
Correct.
What kid gets labeled as suspected sepsis and rule out sepsis and cultured because of a choreo diagnosis.
Right. And it's 3.2 versus 4.4. So right. There's still a 1% difference. And it probably, you're absolutely right, has to do with the choreo. And again, more babies that are born to moms with choreo will have that fever, will have the temperature, they'll have the tachycardia, they'll have leukocytosis, which doesn't actually mean that they're infected, but they'll have those. So, lacerations. There was no overall difference, but they did break it down. There was no difference in second degrees, but there was in fourth and third degrees, and there were more fourth and third degrees in those that started pushing immediately. It was 5.3 versus 4.3%. And that's another one I'm not really sure that I understand. I mean, you would think that... the more time the perineum has to stretch, maybe there would be less third or fourth degrees, but we're not really talking about perineal stretching here because we're just talking about laboring down to like +1 or +2 before you start pushing, and that really shouldn't have that effect. Although maybe it does. Maybe we can get a urogynecologist on here who will tell me that just the baby sitting at +2 for 30 minutes might stretch out the levator ani a little bit, and maybe you won't get as bad third or fourth degree tears. That's possible. I don't know. What do you think, Jen? You're the gynecologist amongst us here.
I was very skeptical about that number, especially because there was no difference in the second degrees. And if there's no difference in the second degrees, I'm really confused as to why there would be a difference in the third and fourth.
I mean, maybe one thing is, I know there's been actually a push to further break down third degree tears in terms of class. So I don't know if a larger swath of maybe second degrees were being maybe called third degrees, or the other way. You know what I'm saying? Like, again, standardization. This is you had 6 different institutions, hundreds of different practitioners. I don't know, definition wise in terms of third degree. Some places are getting more and more specific, and honestly, third degrees in some places are becoming quality measures. And some places are reporting things a little differently. My guess is physiologically, you're right. I think people will argue that a head resting in the pelvis does allow for, greater natural stretching and may allow for more accommodation. But yeah, it's kind of a mystery to me too.
I mean, maybe they weren't spending the time to put the hot packs on the perineum with the immediate pushing group.
Hot packs on the perineum.
Well, there's been evidence to show that hot packs on the perineum prevent laceration.
I'm not familiar with that.
So, I mean, maybe they're just not spending as much time doing things like that in the immediate pushing group.
Okay.
Or not asking for 6 pounds of gel every 4 minutes between pushes. That was always my favorite. My favorite voodoo. Can we get some more gel?
Well, when you have nothing else to do and you're just standing there,
Exactly.
That's the problem
that's
with
the
doctors.
saddest part of it all.
Like a midwife will just sit there, and she can sit there for an hour watching pushes. We have to be doing something. It's just our fault. It's our makeup. As a side note on the third-degree lacerations, I was taught through my entire residency and early attending ship that there are no partial third degrees. It's a third degree, or it's not a third degree, or it's a fourth degree. And now we have partial third degrees. We have 3A and 3B. So.
Right, 3A, 3B, right.
So I found that's humorous. And then they get into satisfaction, which I did talk about at the beginning of the episode here. And they use this McKay Childbirth Satisfaction Rating Scale, which for my life today, I could not find. So I actually have no idea what questions are asked in it. And I looked hard today, real hard. But apparently it gives you a score in the single digits because both groups had a score of 5. And it was not significance. But that is something I want to look into further because I'd never heard of this satisfaction rating scale before. And I feel like it might be good from a patient experience thing just for our own unit, not for research, but just to keep track of our patient satisfaction and see if we change something, does that change our scores for the hospital? So anyway, I look further into that. I don't know if either one of you have heard of it before.
No, I hadn't.
Haven't.
Okay. The first publication I could find that mentioned it was like in the early 2000s. So it's, I was going to say it's relatively new, but that's not relatively new anymore. It's like almost 20 years old.
I would love to see this study redone without epidural. And then I think you'd see some widely different patient satisfaction scales.
You definitely would.
Definitely.
Yeah. And then I like this next one is they asked the women after they delivered, would you prefer to use the same method again in your next delivery? And there was no difference between those two. And I thought that was an interesting way to go about figuring out if people were happy with the their method. I don't know if I would have thought of asking. It's a very simple question, but I'm not sure I would have thought of asking it.
I just don't. These are nulliparous women that just received their first baby during a labor they'd never done before. I don't know what their basis of comparison is other than that experience right there. So I don't know how much validity to put into it, Like, how do they know? Well, how do you know the difference?
Well, I'm not saying it necessarily valid, but at least it gives us an idea of whether they hated it or not.
I'm with Jerry. I don't think they have a lot of experience to draw on from. Yeah.
I'd have to wait for the second one.
All right.
Let's switch their groups for the second one, and then we'll ask.
All right, so we're going to do a randomized controlled double crossover trial.
Of these women in particular. I want these patients.
They must get pregnant in the next 18 months so we can do it. So
They sound awkward.
All right. Anyway, I thought it was cool. You guys don't. That's fine. We can disagree. They write a very, very nice conclusion or discussion, which I'm not going to spend a lot of time going through. Readers at home can read it if they like. It's very nice. I'll read their conclusion, though. Among Nulliparous women receiving Neuraxial anesthesia, the timing of second-stage pushing efforts did not affect the rate of spontaneous vaginal delivery. These findings may help inform decisions about the preferred timing of second-stage pushing efforts when considered with other maternal and neonatal outcomes. Now, the first sentence is fantastic. The second sentence is like grade A BS. But it's well done. It's grade A. It really says something without saying anything at all, doesn't it?
I mean, you have to give the wiggle room. That's the bottom line. I mean, you have there, especially if we are talking more and more about, low risk women having midwife care for their labors and deliveries, you have to have this kind of broader stroke, because now we're already, so if you think about the last 5 years of obstetric literature, we are now telling people to rupture women at 2 centimeters, bring them in at 39 weeks and start delivering them. And now let's have them start pushing once they hit 10. This is enough to cause a good swath of our fellow providers to go haywire. I mean, it really literally sounds like we are just, treating pregnancy and labor and delivery like a time bomb, and that we need to stamp out every last possible risk of bad outcome because the doctor might get sued. Like, it's just a fascinating pendulum that's swinging in the medical literature. But meanwhile, at the patient level, the pendulum's swimming the other way. And I feel like we're kind of reaching a real strange time in obstetrical labor management where doctors and patients are going to start speaking completely different language or different expectations. Does that make sense?
I think it makes a lot of sense. I think you're already seeing patients trying to escape from traditional medical care and relationships with physicians, and finding ways that they can feel more comfortable, not only with their birth experiences, but with the way they receive care in all aspects of their health.
Right. Yeah, we haven't tackled that particular paper yet on induction at 39 weeks here on the podcast, mostly because I'm afraid for my life. But, as we said earlier, women are heading towards demedicalization, as Jen just said. And our literature, as you just said, Jerry, is pushing us towards medicalization. And there has to be some give there. My concern, and I think I err on the side of, or my bias is towards demedicalization, for some very important reasons. I mean, yes, if we induce 30,000 women at 39 weeks, maybe we'll save one bad outcome, right? The literature is not like it's amazing. It is better, right, but it's not like a cure-all. But what other problems, and I'm not talking about medical problems, what other problems are we causing by inducing 1,000 women at 39 weeks, from cost of their management and time in labor and delivery and the number of labor and delivery units and beds and postpartum beds and all the stuff that we have in our hospitals? Like, I'm not sure that the medical field is ready for that. I'll step back. I know we're not ready for that.
No, I mean, I think some of these studies in some ways are a solution looking for a problem. You know what I mean? Like, the conclusions in this paper, very well done. There's definitely significant stuff there. But in the end, there's nothing here where if a woman hits 10 centimeters, suddenly I'm like running to their room to tell them to start pushing, because there's a paper that showed me that 50% of the kids that wait an hour to start pushing, end up in the NICU and end up, with problems. Like, it's a great paper. It's a great outcome, solution for, again, a problem I'm still kind of looking for. Same with the 39-week induction.
I think my concern, come back 1 second to the 39-week induction paper. My concern is it's kind of like mammograms. It took us 20 years, maybe 30 years of doing mammograms on every woman over 40 for how many years every year to determine that our rate of false positives was so high, and we did all these other downstream effects that we didn't think of. It took us 20 or 30 years to even realize there were those effects, and people will start thinking about them. And the same thing with pap smears. And I feel like if we start doing that with the 39-week induction, we're going to end up in the same spot 10 years from now saying, oh my God, how do we do this to ourselves? And not that this pertains to this paper necessarily. Right, that was my rant. I apologize. But it got stuck in my head. I had to get it out. But your last comment, Jeremy, brings me to my last question is, and I'll start with Dr. Blaber here. I know you don't practice OB anymore, but it hasn't been that long since you have. So how would this paper inform your practice, or would it not at all?
I think it's something that you can bring into the discussion with a patient, that, there may be an increase in chorioamnionitis. There may be an increase in some of these smaller secondary outcomes that we talked about. But the fact of the matter is that there's not going to be anything glaringly different between their outcome if they're not ready to push right now. And I think that it's something that can definitely be brought into the discussion, but I don't think it's not going to be making me run into the room at 10 centimeters dilated and, grabbing the nurse from the break room to start pushing.
Right. Fair. And Dr. Ballas kind of already shared his opinion on this, but how about you, Jerry?
Well, I'm going to consider other maternal and neonatal outcomes in order to inform my decision of preferred timing for second stage. I mean, I am. It's really, you're going to, everything kind of goes into account. You got to talk to your patient. You got to talk to your nurse. You got to see what your labor floor is like, see what the tracing is like, see what the person's labor course has been to that point. But I don't think this is going to dramatically, when I tell a woman to start pushing universally across, is not going to suddenly float up to the top of the algorithm as to what I'm going to discuss with a woman when she becomes fully dilated. That makes sense? Mm-hmm. It's nice to have in the back pocket, though. It really is. The other way to look at, say, the 39-week induction, or even this paper, is now we do have some literature in our back pocket to say, well, we're not necessarily doing harm, if we want to start pushing, right? I think seeing no significant difference in I see no significant difference in any irreparable issues. I think that's actually somewhat helpful for us, but it doesn't have to drive any significant change in practice.
Fair enough. I think there are a couple more points I want to bring up. Actually, first I wanted to go back. I didn't mention that when they redid their power analysis with their actual numbers, they were powered to detect an 8% difference. But that their numbers were so close and this confidence interval was so close that they don't think it matters. And that's in the limitations, but I forgot, we're going to talk about that and I forgot. Yeah, and so then my other point, or the thing I want to bring up is, you both mentioned having a conversation with your patients based on this data. And I talked about this in my last aneuploidy episode about, it was probably controversial, about informed consent, about informed decision-making, and how it's kind of a fallacy. It's something we should strive towards, but a patient can never really be truly informed. I mean, hell, I do this for a living and I'm not truly informed. And that's because we just don't know everything. It depends on what paper you read last, right? And so one of the examples I was thinking of while you were talking, Jen, was epidurals, because that's kind of the basis of this paper, part of it, right? Is, do we tell a patient that they're delaying their labor when they get an epidural? Do we inform them of that?
No.
Oh, yeah, you can definitely get an epidural, but your labor is probably going to be like an hour longer or 3 hours longer, right? We don't do that.
No.
Right? So should we do that? Is that something we should be doing? So if with ladies fully dilated and we go in, are you going to have a 15-minute, and I'm not saying you shouldn't, and it's not that 15 minutes is a long time, but you're going to go in there with this paper and another paper and say, hey, these are the risks and benefits of starting to push now versus later? Probably not. You're probably going to defer to whatever the culture is in your labor and delivery unit, or to what the patient wants if she comes in with her own viewpoints and birth plan about what she wants to do. So I think that's kind of a fallacy of ours, of saying that we're going to inform our patients about every little thing as far as labor management. And that's not a question, it's not a comment, I suppose. But for me, this paper at least tells me that either thing the patient wants to do, or I want to do, or the nurse wants to do, because honestly the nurses run labor and delivery more than we do, is okay. And I shouldn't get upset about it.
Right. And that actually, that's what I was going to say. The other side of informed consent, you're speaking from the physician to the patient, but the other way around is they're informing us of kind of what they perceive or desire or what they want. And this gives us at least some leeway and gives us a basis to have that conversation with the patient. So I think that's a benefit. I don't think it necessarily always has to be a one-way, us marching in with all the data and, speaking to the patient from some level of authority. They're going to come in with this data. I guarantee this is already on mommy boards everywhere, left and right. And it's going to be spun as, don't let your doctor say you need to come in and start pushing because, look, there's no difference.
You're probably right. And I think it is an important point, and I was thinking of it, but you articulated it better than I did, about having data for when your patient is already informed or at least partially informed and comes to you with that question, which is a different kind of conversation than you going to them and they are not informed already and you have to give them a recommendation. And how much information are they ready to absorb or can they absorb based on their own education level? And that's the hard thing to judge. Right. Some people have no education but are very intelligent, and other people have a lot of education, but are not prepared to understand whatever you're going to try to tell them, right? So that's always our challenge too. And now I've gotten off track here, but in any case, I think we all agree that this is a very well done study. It's a very well written paper, and you can interrupt and tell me you disagree if you do. And
it's a very well written paper about meh.
How do you really feel?
Well, I mean, like it's a very well executed study with a very well written paper with a very boring take home message.
Fair. I think this is what Jerry was getting to earlier. It is. And he didn't say it like this, I'm putting words in his mouth, but if we were going to spend all this time and resources, maybe we could have tackled the more clinically relevant question.
Right.
I don't know if I'm putting words in your mouth there, Jerry, but I think they were similar when it comes to how we interpreted this. So yeah, you're absolutely right, Jen. It was a question I wasn't burning to know the answer to.
And it was so huge. It was a huge study. I was like, we had 2,400 women in a study. God, I wish it was about something else. Yeah. You know what I mean? Like, how often do you get these powerhouses to collaborate on a non-SMF unit trial study? And we wanted to know about an extra hour of pushing. Okay. Before I get myself into trouble.
No, I picture the manpower that it takes. Like stop everything. Someone's fully dilated. Let's go log into the website to get her randomization,
right.
done. And yet they're not saving people's lives. Like the question is not saving people's lives.
No, it's true. The one last question I have for both of you, and this is more kind of an inside baseball, I suppose. This is a very big study done by very prominent people in the MFM community, and it was published in JAMA. Now, JAMA is not a nothing study, a paper. I mean, journal, obviously, right? It's definitely up there, but it's an odd journal for this kind of paper that doesn't usually get published in this kind of paper. This paper, not usually in this kind of journal. So, I don't know, why do you think they chose JAMA?
I think we've already figured out why they chose JAMA, right? Because we just spent the last 5 minutes talking about the fact that this is a take-home message for our patients. As Jerry said, this is a paper your patient's going to come to you talking about. This is something that's going to hit the news, right? And so that appeals to JAMA, because it's a newsworthy paper. Whereas for us sitting here talking about it tonight, it's not something that we actually want to read about. It's not a question that was burning in any of our minds. But for a patient, this is going to be something that they might come to us with. And so that'll get them the news factor, the JAMA publication.
Yeah, no, I think that nails it right on the head, honestly. That's when you go for Green Journal, when you go for New England Journal, when you go for the Gray Journal, you are looking to directly influence your colleagues in that world, in that practice of medicine. They knew, just like we've already discussed, the different levels of labor management in a labor floor that does not involve physicians, right? We are the sixth or seventh layer of that onion, right? And so they knew going to Gray Journal, how many of us are going to be like, great, but I don't think the charge nurse is going to go for that, right? We know our limitations, and that's good. That's what we're supposed to know, right? But I think Jen nailed this on the head, that this is going to go to, very publicly accessible, easy to read, and more of a general audience.
I mean, and it did. I've already seen this linked to in a couple of general news outlets. So it definitely had the intended effect. I mean, I think we all agree that this would have been published wherever it was submitted to, right? Like, there are some papers,
of
right,
course,
that you submit them to a lower quality journal because it's not going to get into the other ones, or you tried the other ones first and they didn't get in. This paper would have been published in AJOG or New England Journal or
this would have
Green Journal, right?
Yeah,
I mean,
absolutely.
So they chose JAMA purposefully, and I agree with Jen. I think that was exactly the reasoning behind it. It was very smart.
Oh yeah.
So, all right, a little inside baseball, but interesting. All right, so before we say goodbye, do you guys have anything else you're burning to say about this paper, or about this topic in general, before we close up?
No, nothing beyond kind of what I mentioned before. I am a little worried the direction our field may be going. It's almost tone deaf, to tell you the truth. I think there's a little bit of tone deafness amongst the higher echelons of obstetricians and high-risk obstetricians in terms of, what the burning questions right now of the public, of labor, of pregnant women, of women in general, when it comes to managing their pregnancy and, the general climate right now of where pregnancy management is going, to keep coming out with these uber medicalized, very much, in the realm of physicians. I wouldn't even say providers, I could say physicians' hands in managing pregnancy and prenatal care and labor. So I don't know how to control for that, because we are in our own worlds and that's what we do on a daily basis. But I've started to take kind of a more general approach to where our knowledge ends up, where our papers end up. And I think there's a divergence happening right now that we need to address.
I don't think I have anything to add after that one.
I think you said it well. I do, because Jerry and I were talking about it earlier today and the last couple of weeks. Jerry is the president of the
as of January,
you will be the president of the
National Perinatal Association.
Okay. And there is a conference coming up in April.
Yes. So in April, the dates are off the top of my head, but April, I want to say 6th to the 9th. It is our conference addressing disparities in healthcare access and healthcare quality amongst the women in the perinatal period. And so it's taking a very multidisciplinary approach to a very, very stark problem in our country. And, it is coming from a place of varied providers of women, for women in the perinatal period, stretching from physicians to midwives, all the way down to your social workers and your psychologists. And we have legal advocates coming as well. So, it's definitely started to color how I view a lot of the research that comes out of our strictly medical world.
And that is in Providence, Rhode Island.
Providence, Rhode Island. I can link it. I can give you the info to link to the notes page of the episode if you'd like. And we are planning possibly a little bit of a conference podcast, something or other.
We're going to do something.
Love it.
Is it open to non-members as well?
Correct.
Okay.
Yep.
So I'll definitely put the link in the show notes. Those who are interested. Jerry and I will definitely be there. Maybe some other people from the podcast. Who knows? We'll talk more about it as we get closer. But put a pencil in your calendar if that's something that piques your interest. And with that, I will say thank you, everyone, for listening. Thank you, Dr. Blaber, for joining us.
Thank you very much for having me.
And thank you, Dr. Ballas, for coming back.
Thank you, sir.
And remember that if you do like what we do here and you want to support it, please click on the link in the show notes or go to the website and throw a few bucks our way if you can do that. So thank you very much, and we'll see you next time.